back to Rnpntutors USA. Don't forget to like, share, and subscribe. So today we're going to talk about maternity nursing, how to assess the fetal heart rate pattern. A lot of students struggle with this in nursing school, and it's not that bad once you understand it. To assess the fetal heart rate, what we think of as stable heart rate is usually considered 110 to 160 beats per minute. Bear in mind that we don't want to see smooth lines on our strips. We want to see beat-to-beat variability because that's our reassurance that both the sympathetic and parasympathetic nervous system in the baby is working. So I've drawn here two patterns. This one in black are mom's contractions, and you see three different contractions here going across, right? In red, I have the baby's heart rate pattern. And so I'm going to show you the difference between the early deceleration in the fetal heart rate, the late deceleration in the fetal heart rate, and what we mean by a variable deceleration in fetal heart rate. So remember that whenever we consider the fetal heart rate pattern, we want to think of the deceleration or drop in heart rate in relation to mom's contraction. So if the baby's heart rate decelerates in conjunction or at the same time or early in mom's contraction, it's considered an early deceleration. So if you look here, the dip or deceleration is occurring in sync or very early with mom's contraction. And so that's considered an early deceleration. It is usually caused by head compression in the fetus, and it's not so bad. We actually consider it a reassuring observation, and we continue to monitor because that's something good. It means that whenever there's a contraction, there's a deceleration in heart rate, but it returns to the baseline, and that's fine. Another fetal heart rate pattern that we want to look out for is the late deceleration. Remember that the late deceleration in the heart rate pattern begins late in mom's contraction. So if you look here, the contraction has started and even gotten to acme, and here we then have the deceleration. So the deceleration is occurring late with mom's contraction. And so whenever there's a late deceleration, this is not reassuring. This is really bad. It's considered an ominous sign. You always, whenever there's a change or instability in fetal heart rate or any distress, you want to put mom on the left side. Left lateral recumbent side. You want to give mom some oxygen, and you want to stop Pitocin if you still had Pitocin infusing. So that's the late deceleration. Heart rate drops late with mom's contraction. See here, the contraction is ending. Our variable deceleration is shown over here, and usually a variable deceleration is not so much related to mom's contraction. Usually what you want to do is change mom's position to Trendelenburg position, and you're doing that because of cord compression. A variable deceleration is not usually related to contraction, and it's usually caused by the umbilical cord being compressed by some presenting part or something else in mom's body. Usually something is pressing or compressing the umbilical cord. So what we have to do is change mom's position to Trendelenburg. If we lower mom's head, the belief is that the baby's body by gravity will bounce backwards, and that will take some pressure off of the cord. We also want to check if there's a variable deceleration. We want to also check for prolapsed cord, because what that would mean is that the cord is presenting before the fetus. And if we do notice that the cord is there, we have to protect it and cover it with sterile soaked gauze. It has to be soaked and could be saline, has to be wet gauze, because we don't want the cord to start to dry up. And then of course we're going to be prepping mom for a C-section. So again, we have the early deceleration, which happens early with mom's contraction. It is a reassuring sign. It means that something may have touched the baby's head, and we usually just continue to monitor. The late deceleration begins late in mom's contraction. The heart rate drops late in mom's contraction, and with a late deceleration, we know it's an ominous sign. Late starts with L, left lateral side for mom. We also want to give a lot of oxygen via face mask, and we would love to stop Pitocin if there's Pitocin infusing. Again, a variable deceleration is not necessarily related or happens in sync with a contraction. So here it says it's not related to the contraction, but of course, again, it's considered the etiology is cord compression. And so we want to change mom's position. We know Trendelenburg helps. We want to give oxygen, and again, we check for prolapse cord. So in order to remember this, a quick way is to use the mnemonic VAIL CHOP. The V for variable deceleration, and again, that's caused by cord compression. The E is for early deceleration. Again, etiology is the baby's head is compressed. An acceleration or speeding up of the heart rate is okay. It's a reassuring sign, and we just monitor mom. And then of course, our late deceleration that begins late in mom's contraction. It's a drop in heart rate late in mom's contraction. We know that that means that the placenta is not sufficient. And so again, it's an ominous sign. It is not good. We want to turn mom on her left side. Turning a pregnant woman on her left side relieves compression off of the great major blood vessels, including the vena cava. And so this will cause more oxygen and blood flow and nutrients to the baby. And of course, we're prepping mom for a C-section. Like, share, and subscribe. And remember to join us again for another video.